righty. Just wanted to thank everybody for joining us tonight. We're going to talk a little bit about something called prostatic artery embolization. My name is Brian Wong. I am an interventional radiologist, board certified. I work with Urology Partners of North Texas, as well as IR centers. So I have no conflicts of interest. Let's see. So we're just going to go over a couple things, a little bit about me. I got my medical degree at Texas Tech University, and then we went to University of Texas Medical Branch for radiology residency. I then completed my interventional radiology fellowship at Miami Cardiac and Vascular Institute, and I am a board certified interventional radiologist, as well as a registered physician in vascular interpretation. So let me just pull this up. As far as clinical interests, a lot of what I do is treating benign prostatic hyperplasia. I also have interests in peripheral arterial disease, venous disease, and treating osteoarthritis. If you have any interest in any of these things, I am more than happy to talk about it in a future webinar. All right, so what is benign prostatic hyperplasia? This is a non-cancerous prostate enlargement. It's a very, very common condition that a lot of men have, and it increases with age. As you can see on the chart on the right, the incidence of BPH increases about 10% every decade. So at 50 years old, about half of men have BPH. And that number increases up to 90% at age 80. Thankfully, there's many treatment options for enlarged prostate. You can see in this diagram right here, this is what a normal prostate should look like. On the right, there is an enlarged prostate that you can see is obstructed and narrowing the urethra, which is what can cause a lot of problems. So, why does BPH happen? There's a lot of reasons, and we're not 100% sure, but some of the factors include aging. There's family history, so there's definitely a genetic component to enlarged prostate. Hormones can affect BPH, so testosterone use, and it also has been tied with race as well as metabolic syndrome, so cardiovascular health, diabetes, hypertension, obesity. These are all things that can be correlated to enlarged prostate. So, how does it happen? BPH happens with proliferation of nodules around the urethra. There's growth of nodules that narrow the exit of urine through the prostatic urethra, or the tube that connects the bladder to the penis. This compression results in multiple problems, mainly urinary obstruction and retention. So, problems with getting the urine out of the bladder and problems retaining too much urine that can lead to other problems, such as stones in the bladder, urinary infections. The bladder itself will actually change. So we can see chronic compensation that happens. You can actually measure the thickness of the wall of the bladder and find that it grows trying to push urine out of the bladder. We can also find pouches when the bladder is trying to squeeze too hard. We can see what we call diverticula, and these outpouching further worsen the contractility and how well the bladder can push urine out. All right, so this is another illustration of what we're talking about. You can see these chronic changes, and they collectively result in what we call lower urinary tract symptoms. So a lot of what we call lower urinary tract symptoms, hesitancy, so the problems with starting and stopping, intermittent stream, we can see straining to void, incomplete emptying, and these are some of the chronic changes like we talked about, bladder wall thickening and these diverticula. There are some medications that we will cover later in regards to some options for treating enlarged prostate. So these are collectively what we refer to as lower urinary tract symptoms, or LUTs. There's two types of them. First type is voiding. So problems getting the urine out. These include incomplete emptying, stop and start flow, weak stream, straining to urinate, and they're basically from the prostate blocking the bladder from emptying. We also have storage symptoms. So these are more so related to the bladder itself. We have frequent urination. You have sudden urge or urgency. And we also basically problems with holding in your urine. A lot of patients wake up at night with nocturia multiple times and have problems going back to bed. So this is what we refer to as the International Prostate Symptom Score. It's a validated score, the IPSS score, that looks at these symptoms of voiding and storage. And it is a standard part of evaluation for enlarged prostate. So what can happen with enlarged prostate? Over time, some of these issues can result in recurrent urinary tract infections. You can have bladder stones. Sometimes, if the bladder gets blocked, and it can back up to your kidney and result in kidney failure. Other complications, you can have urine leakage or incontinence, and that may actually result in the use of a Foley catheter or a bladder catheter that may be long-term or possibly permanent. Now, it's important to recognize that enlarged prostate does not increase your cancer risk. So these symptoms that we mentioned before, the lower urinary tract symptoms, there's a lot of different causes, and enlarged prostate is one of these causes, but not the only cause. So it's important to have a urologist see you before to rule out some of these other options, because enlarged prostate is not the only cause of lower urinary tract symptoms. Now, the other causes are definitely beyond the scope of this talk today, but other problems do include overactive bladder, neurogenic bladder. You can have chronic inflammation in your urinary tract, prostatitis. You can have strictures or narrowing in the urethra. So these are things that must be excluded or evaluated before I see you for enlarged prostate. So why is this important? Well, about 15 million men in the US have enlarged prostate. And a lot of them don't end up seeking treatment for it because they're afraid of the side effects. So there's side effects with medication, with treatment, with surgery. What's the workup for an enlarged prostate? So a normal prostate is about the size of this ping pong ball. And you can see different sizes of prostates. So 25 grams is what's considered normal. The first step is probably performed by your urologist, the digital rectal exam, and they can assess nodularity to your prostate or lumps and bumps on the back of your prostate. This is important because with some nodularity, it can suggest cancer. Once that's evaluated, other things we do is urinalysis. We can basically look at your urine, try to grow bacteria out of it and look for a urinary tract infection, rule out one of the other causes of lower urinary tract symptoms. Sometimes we can also assess for blood, whether that comes from the kidney, from the ureter, from the bladder, or the prostate. That has to be worked up as well. The PSA is important to assess for cancer risk. So that's a test in your blood, and something we watch very closely to assess whether you need additional studies to evaluate for prostate cancer. One important study that we look for is the bladder scan. So patients urinate, and afterwards we can scan your bladder and see how much urine is left inside your bladder. This is also what we call your post-void residual. And this will give us an idea of how much your prostate may be blocking your bladder from emptying, or at least incomplete emptying. All right. So these are some more advanced studies that we do to assess your bladder function. First of all, you have urocuff testing. So you urinate and it makes a different chart right here. So urodynamic testing. is a more advanced study where they put a catheter inside your bladder and see how well your bladder is squeezing. And that's a large part to make sure that if the bladder is working, then we can see how, I guess, assess your outcomes once we fix the prostate blockage. The cystoscopy is a big part of the study as far as evaluating your enlarged prostate. And this can see whether you have other causes of lower urinary tract infections, such as urethral stricture or narrowing in the tube that connects your bladder to your penis. You can also assess the degree of obstruction that the prostate is causing. So this is a picture on the right of a cystoscopy exam, and you can see different lobes of the prostate narrowing the urethra. We can also assess the bladder. So the urologist will do the study, and they can see thickening in the wall of your bladder that correlates with chronic narrowing or blockage. They can see things like diverticula, like we mentioned before. As far as imaging, different tests can be used to assess the size of your prostate. So one of them is the transabdominal ultrasound. There's a transrectal ultrasound. You can see these images to the right give us an estimation of how large your prostate is. We can also do a CT or MRI, which are more advanced studies that can assess what your prostate looks like. They can give us an idea of the morphology of your prostate, which parts are blocking the urethra, and that helps us come up with a tailored plan to assess, to treat you. Another workup for enlarged prostate would be the prostate needle biopsy. And if there are any suspicious lesions, a urologist will take a small sample and they'll see, this will assess your risk of cancer. So there are many different treatment options for an enlarged prostate. We like to start off with what's least invasive and what's least costly to the patient. So this starts off with lifestyle changes. We encourage patients to first try all of these before medications, double voiding or voiding and then attempting to void afterwards. That helps make sure your bladder is emptying. Avoiding liquids after a certain hour so you can get through a night of sleep. Certain medications and different things like caffeine, wine, alcohol, chocolate, they can irritate your bladder and cause it to be a little more aggressive. So avoiding these bladder irritants can help with your symptoms. Certain medications can also cause issues as far as the bladder goes. So antihistamines like Benadryl, Sudafed, as well as some opioid pain medications can affect your bladder. Medical management is an option for a lot of patients, and these are the two common groups of medications that are used to either relax the prostate muscles or to shrink the size of the prostate. Now, these medications each come with their own side effects, but they work relatively well to keep most patients' symptoms at bay. So the alpha blockers, tamsulosin, also known as Flomax, alfuzosin, these medications help relax the muscle tone, but they do not reduce the prostate size. They can cause dizziness and lower your blood pressure, as well as cause issues with ejaculation. The other class of medications are the 5-alpha reductase inhibitors, and they actually shrink the prostate. Now, these block basically your hormones, so it reduces the size of the prostate over time. These will be your finasteride, your dutasteride, and these take time to shrink the size of your prostate. There are many options as far as surgical options that I'll go over very briefly. And typically we consider some of these once patients have failed medication or unable to take medications due to some of the side effects. The TURP or the transurethral resection of the prostate, is also known as the Roto-Rooter, is what's considered the gold standard for an enlarged prostate. It works very well as far as getting the strong stream when you measure it on paper, but can come with some side effects. So one of them is retrograde ejaculation, that's commonly mentioned. This procedure is performed in the hospital under general anesthesia, and typically you have to go have a catheter placed, but it does work well, and it is what's considered the gold standard. There are many other treatment options that exist. Collectively, they're known as MISS, or the minimal invasive surgical therapies. And here's some of the surgical therapies. So on the top left, this is the Urolift. It's an in-office procedure where clips are placed within the prostate, kind of like pulling apart the walls of the prostate. And there's a suture that holds this wall open. So this is an in-office procedure that can be performed. This is another in-office procedure. This is called the Rezūm, and this is a transurethral procedure that's performed in the office where a needle is inserted and hot water vapor is used to shrink and damage some of the prostate tissue. On the bottom, we have a procedure called the aquablation. This is a procedure that is performed in the hospital under general anesthesia. It works well. How it works is patients will have a probe, an ultrasound probe placed so that they can watch a water jet ablate or take away some of the tissue that supplies the prostate. You can see the probe being inserted, and it's done like so with a water jet without any heat that basically takes away this prostate tissue. All right. So many treatment options exist for enlarged prostate. As far as medical management, this is non-invasive, but there is a cost associated with it. There are side effects that a lot of men complain about, as well as the issue of compliance or patients not taking their medications. Interventional radiology, or PAE, I'll cover more in detail later, but it is an office-based procedure that's minimally invasive. It has great efficacy and lasts about 5 to 7 years. And the most important part, there's no effect on erectile function, on ejaculation. There's no upper limit on how large of a prostate we can treat, and there's nothing that goes in your penis. There are plenty of options as far as urologic surgery goes. We mentioned the Roto-Rooter or the TURP, as well as other minimally invasive therapies. All righty. So what is embolization? Embolization definition is a minimally invasive procedure to occlude blood vessels. So this can be used for many different things, including treating benign growths like BPH. We also use it in the hospital to treat cancers. It can be used to reduce inflammation, for example, in the knee. We use it to stop bleeding, for example, in the gastrointestinal system. If you have any abnormal blood vessels, we can embolize or treat it with embolization. There are many other uses for embolization. So you can see a catheter to the left. These are tiny, small plastic beads that are used to occlude these abnormal and large blood vessels that are supplying this nodule. So these are preoperative considerations for the prostate artery embolization. Compared to some of the other ones, there is no overnight hospitalization, and it's performed with moderate or twilight sedation, similar to a colonoscopy. The patients are in and out of sleep. A lot of them are very comfortable during the procedure, but we do not do general anesthesia with intubation. It's a safer option as well. Patients will need a driver afterwards because they can't drive for 24 hours after receiving moderate sedation. One of the benefits of this procedure is it actually can be performed on blood thinners as well, depending on the blood thinner. Certain contraindications. So these are things that patients are probably poor PAE candidates. So if they've had any issues with allergies or anaphylaxis with contrast dye recently, if they have poor kidney function or chronic kidney disease and they're not yet on dialysis. And the last one is patients must be able to lie still for roughly an hour and follow commands. So this is how a prostate artery embolization is performed. There is no transurethral access through the penis. In fact, for most patients, we don't place a catheter inside the penis or a bladder catheter. This is done with a small femoral artery access. So everything is done under ultrasound. You give a little numbing medication that burns no more than an IV, and we go through a 5 French or a 2 mm access into the blood vessel. It's a pinpoint hole straight into the blood vessel. Here's a diagram of how the procedure is performed. Once we go inside the blood vessel in the thigh, we then navigate this catheter to find the blood vessels that supply the prostate. Once that's identified, we place small beads made of medical-grade plastic to slow down the blood flow to the prostate. This is repeated for the other side. Most of the time, we're able to treat both sides of the prostate through one incision in the thigh. Here's an actual video of what I'm looking at. So, contrast dye is injected into the artery of interest, and we find an abnormal enlarged vessel supplying the prostate. So this video is sped up, but it typically takes about an hour. A small wire and catheter are advanced into the blood vessel, and once we're in the correct blood vessel, we confirm that by injecting more dye. The contrast dye feels warm, and there's a characteristic appearance that we use to find the blood vessels supplying the prostate. Once we've confirmed that we're in the prostate and the beads are no longer, the contrast is not going anywhere else, that blood vessel is only going to the prostate, then we treat it and slow down the blood vessel and embolize it with small beads made of medical grade plastic. As far as recovery, patients, so I use what's called a closure device that closes the hole that I make in the blood vessel, that 2 mm hole. Patients recover for approximately 30 to 60 minutes, and they're able to go home afterwards. During the recovery time, patients can eat, they can keep their legs straight during that recovery time. They're not allowed to drive after receiving sedation. And as far as restrictions, no heavy lifting for 1 week. Unless you had a recent episode of acute retention, then no bladder catheter is needed. And this is mainly for patient comfort. What to expect after PAE? So in the first 1 to 2 weeks, about 30% of patients can have increased urgency, meaning they need the sensation to pee. You can only get a little bit out. They can have some burning when you pee. You may be going more frequently. And in general, your symptoms may get temporarily worse for up to 10 days. We give you medication to take the edge off it. And after about 10 days, you should start feeling better. After about a month, there should be mild improvement. And that improvement continues over the course of 2 to 3 months. As you can see on the image in the top right, it's a prostate before an enlarged prostate. And afterwards, this is what a prostate looks like after it's been treated with the prostate artery embolization. Shrinkage is roughly 40% according to studies. It is repeatable, but typically can treat you for about 5 to 7 years. If symptoms come back, we can retreat you. And it also doesn't burn bridges as far as other options go. As far as the risks go, so there's a couple worth mentioning. They're very, very rare. PAE is an extremely safe procedure, but every procedure comes with some risks. Access site injury. So sometimes whenever we're closing the vessel, there can be a small amount of bleeding around there, very rare with closure device. If anything happens, we're able to treat it on site, and typically holding some pressure takes care of it. There is a small risk of infection, so patients are placed on antibiotics, and we also hold off on the procedure if patients had any recent urinary tract infections or episodes of acute prostatitis. There's a very small risk of retention, which is increased if you've had an episode of recent retention, but that number is extremely low. The last thing to mention is there's a risk of what we call non-target embolization, or a fancy word to say we end up slowing down blood flow where we don't intend to. It happens very rarely, less than 1 in 100 patients, and most cases actually are self-limiting and they heal by themselves in a matter of time. What can happen is you may have blood in your urine or blood in your stool that typically lasts for a week and goes away by itself. Or it has been reported patients can get a small scab on the tip of the penis, which heals by itself as well. These are extremely rare cases, and they do heal by themselves over time. So, who is a candidate for PAE? Patients with enlarged prostates. So, typically 40 to 50 grams is a good size. If you have bleeding coming from your prostate or hematuria, excellent candidates for for PAE. Sometimes patients have an extremely large prostate, and we have done this procedure for patients who are receiving other surgical therapies for enlarged prostate. Patients who have tried medications or have had issues with some of the side effects of medications, this can get you off those medications. Patients with catheters in place, this works well to get that catheter out as long as the bladder is working. Patients who want to preserve their sexual function. So if you want to protect your erectile function and your ejaculatory function, this is one of the few options, especially for ejaculatory function. Patients who can't receive surgery are a good option as long as you're able to lie flat for about an hour. This can be used in the setting of prostate cancer prior to receiving radiation therapy. And if other procedures have not worked, this is an option for you. So here are some of the frequently asked questions that I get. First one is is PAE covered by insurance? So it is covered by Medicare in most major insurance plans. Every policy is slightly different, but in general, it is covered by insurance. What are the beads made out of? So the beads are made out of different types of polymers, different types of plastics. Everyone's slightly different. Some are made of gelatin as well. What happens to the beads? So whenever I place the beads in the blood vessel, they are permanent and they block what we call your native prostate artery. So they line up in there so that the red blood cells can't deliver oxygen and nutrients to the prostate. This will cause the prostate to shrink roughly half in size over the course of 3 months. Now, get a common question, can the beads travel and dislodge to the heart or brain or cause blood clots? This is a very common question. The beads can only go next to the prostate artery. There's no risk of it traveling anywhere else the way that I do this procedure. So by going through the groin, there's no risk of stroke. There's no risk of heart attack other than those beads going elsewhere, like I mentioned before. Do I still need to take my medications after PAE? So in general, I recommend staying on your BPH medication for at least 3 months while your prostate is shrinking, just so we don't take you off that medication prematurely. And you will have a follow-up with me, typically around 1 month. And then at 3 months, you'll see your urologist who is prescribing your BPH medications. And at that follow-up, depending on how you've responded, a lot of patients, and majority of patients, are able to get off or at least decrease the dosages of their medications. All right, here's some educational information about enlarged prostate. So we have a pamphlet. If you haven't received it, you should be able to receive this at your urologist's office. These are some of the other things we do. So these are other procedures. Embolization in the knee is a common one. Let's see. So these are other things that we treat: varicoceles, knee arthritis, and erectile dysfunction, hemorrhoids. And these are other settings where embolization can be used. All righty. Take some questions now. If you want to join the chat and just type in your questions, I can read them off one by one and go over them. Let's see, where's the chat? I have some questions that I've received on the by email, so I can go over some of them, but let's see. Chat. If anybody wants to add any questions to the chat, now's the time to do so. All right. So one of the questions I've received is, let me pull this up right here. Isn't reducing blood flow to the prostate dangerous? So we've done studies and we found that there are some risks to reducing the blood flow, but in general, we cover for infection. The prostate actually is pretty safe space and it shrinks by itself without any risk of, I guess, necrosis or anything like that. Necrosis happens and the prostate shrinks down in size, but patients typically don't get any infection as long as we have them on antibiotics. As far as potential risks and benefits of the PAE procedure, let's see. See that you've raised your hand, John. Question and answer. All right. So, what are the potential risks and benefits of the PAE versus other available treatments? So, there's a lot of different other treatments for enlarged prostate. And the PAE is by far one of the least invasive options to the prostate. As far as potential benefits, nothing goes in your penis. There's no sexual side effects risk. So there's no risk of erectile dysfunction. There's no risk of ejaculatory problems compared to some of your other options. The downside is it takes up to 3 months for the procedure to fully have its effect. But it works in about 80% of patients. As long as there's good blood flow and I can get a good treatment into your prostate, patients typically do pretty well. Let's see. Let me see. Okay, I got a question about hemorrhoids here. So I will be having a separate talk at a later point. We can talk about hemorrhoids. This is mostly about prostate artery embolization, but I'd be happy to answer your questions offline or if you want to reach out. I have a question next from Michael. He says, does this procedure reduce the risk of cancer since blood flow is cut off or reduced? So we don't have the data or research to say so. Now, there are studies that are ongoing right now in this area, especially with radioactive beads. But what I can say is it does cause the size of your prostate to get smaller. And it also causes your PSA to go down long term. It initially can go up as a result of the procedure. We typically see that around 1 month mark, and then it drops below its baseline and gives you a new baseline to monitor your PSA. And Dennis said, can we obtain a copy of the slides? I have to double check. I can provide you with some images, or if you'd like to chat about any questions about the slides, I'm more than happy to go over with you. I have a question from Tamberly. It says, how about women in their late 50s? I'm not sure how that applies to prostates, but if there's another procedure you're referring to, I'm happy to address that. Jesus wrote, how is it used to treat mild testicular varicocele or ED? And can it be done at the same time while doing the prostate artery embolization? So typically we do them separately, just for approval reasons, but mild testicular varicocele. So varicocele is another talk, but in general, varicoceles happen when there's abnormal connection between your gonadal vein going down into your testicle instead of away from your testicle, and we can block that abnormal connection. Here is a picture of one of them that I did. So this is that abnormal collection, and we put coils in there to block it. It can be used with erectile dysfunction, specifically with venous erectile dysfunction. Embolization basically it's a type of erectile dysfunction where there's too much blood flow away from your penis, and we can block these abnormal blood vessels, causing too much blood flow going away from your penis. And let's see, keep the questions coming. Next question from Jesus. Could the prostate shrink too much? Very, very good question. We haven't found that to be the case. In general, after shrinking it, it shrinks up to, in my personal experience, up to 60% in size. So in general, I say about half in size, but we can't get it completely out because we're not cutting anything away. There are certain instances when I think that there's too much prostate that patients may actually benefit from a combined approach. So sometimes we work together. We do a embolization before patients have some of their prostate cut away. But in general, there's always going to be blood flow going to the prostate from small vessels, and that's probably why it comes back after a while. Let's see. Next question from Gary here. How do you know if there's constriction in the urethra versus enlarged prostate to cause poor urine flow? Great question. This is something that typically can be addressed by your urologist with a cystoscopy. Constriction in the urethra, I'm assuming you mean like a urethral stricture or narrowing, that can be caused by infection or from placing catheters. You're going to see that in a different part of the urethra that's narrowed from the prostate. So basically a camera can be inserted in the penis. They basically look at the length of the entire urethra from the tip of the penis all the way up into your bladder, and they can see your prostate narrow your urethra like so. Let me see if I can pull up that slide. So this is up high, and these are your lateral lobes of your prostate narrowing and the part that the narrowing in the urethral or the urethral strictures typically looks different. Got a question from Scott here. It says, how would you choose between PAE and aquablation? Great question. Well, a lot of it has to do with considering your side effects. So PAE, aquablation are both great options. There's one, I would look at what you want to do. So as far as what matters to you, are you a candidate to undergo general anesthesia because that's necessary for aquablation? There's other considerations. For example, aquablation, there's a small risk of bleeding, but it works very well. Sometimes patients can have problems with ejaculation. PAE, it takes longer for it to work, but you don't need general anesthesia. We give you moderate sedation, kind of like a colonoscopy and less side effects compared to general anesthesia. Depends on the size of your prostate. So if it's extremely large, PAE works pretty well for those prostates. Oh, got some more questions. Keep them coming. John asked me, I'm interested in your history of performing this procedure, a little background giving rough estimates. How many times I've performed this? So I started out in Louisville, Kentucky, and joined prostate centers 2 years ago. Performed this procedure roughly, I've lost count, but around 1,300 times. I've been training doing this procedure, and I've been doing this full time for about 2 years. And before that, you can add probably another 2 years training to doing it. In general, more than 50 procedures is what they recommend, but I'm very comfortable with the anatomy after doing this about 1,300 times. Doug asked me, is there an age limit for this procedure? My oldest patient was 97 years old. So I'm willing, if you're able to lay flat on that table, if you're comfortable, we may be able to push that farther. But 97 is what my top is so far. Bernard asked me if my urination is fine, meaning when I get the urge to urinate, it's probably due to medication I'm taking. Should I be happy and just continue taking my medication? It depends on you. So, what I mean is, are you having any side effects related to the medication? Or do you just want to stop taking the medications? Some of them have sexual side effects. Some of the finasteride that can have decreased libido, affect your sex drive, can have in your energy as well. So it really depends on you. If you feel like those side effects are worth it, or you're not having side effects and your symptoms are relatively mild, um, then and you're sleeping okay, then by all means you can keep doing whatever you're doing. But if you feel like you just can't take it anymore, then we can talk about different options for you. All right. Dennis asked me, how is it determined if a prostate is 40 grams or larger? So one is seen as a good candidate for this procedure. Great question. We do imaging. So a digital rectal exam, not very accurate, but it can evaluate for nodularity or risk of prostate cancer. We do ultrasounds, so we can scan you with a probe outside right on top of your bladder and look through your bladder to see your prostate. That's it's not the most accurate way, but it can tell me if you have a very, very large prostate. A more accurate way would be a transrectal ultrasound, and they would put a probe inside your rectum. An ultrasound probe goes right next to your prostate, and it can measure just like this how large it is. We have a formula, and basically we measure how long it is, how wide it is, how tall it is, and calculate that number to see whether it's 40 grams or larger. Um, if you don't want to have a transrectal ultrasound, or you don't tolerate that well, we can do a CT, we can do an MRI. So this is an MRI. Basically, we do these same three-dimensional measurements to see what your prostate looks like. That can also look at your bladder and see wall thickening and other things as well. So that's a great question. I think that size is definitely a big consideration because larger glands in general typically do better. All righty. Jesus had a question. I have quite a few questions. Let's see. Back to the ED question. Is it correcting a blood flow leak, and would it be possible to correct at the same time with the prostate embolization? So they would be done separately, but we have to confirm, one, your prostate is, you're a good candidate. So we have to rule out some other causes of lower urinary tract symptoms. And you can start with your urologist at Urology Partners of North Texas. UPNT that can help you rule out other causes of why you're having problems urinating. And then if it is your prostate, then we can talk about PAE. As far as the ED question, that will be the subject of another talk. But in general, there can be a leak of blood flow Normally, there are many causes of ED, and one of them is too little blood flow going into your penis, and the other one is too much blood flow going out of your penis. So we can correct that leak. It's called a venous leak embolization. And basically, helps keep the blood stay in your penis for longer erections. Does this procedure last longer than a Urolift? From Craig. In general, I think the numbers, according to studies, the Urolift says it lasts about 10 years, but that's based off the trial data. In actuality, in practice, I have treated a lot of patients with Urolifts that have lost it shorter than that. So, um, 5 to 7 years is what the PAE typically does, is according to our studies. But I've treated plenty of patients with Urolifts in there. I think that it depends on the morphology, the shape of your prostate, and we can determine whether you're a good candidate for Urolift or a PAE, and kind of tailor your questions based off of what yours looks like on imaging. John asked me, what if you do nothing? Great question. Depends how bad your obstruction is. So if you do nothing, your prostate's going to get larger. As long as there's testosterone or hormones in your system, your prostate's going to get larger and larger, just like the graph that I showed here. I wonder if I can pull this up. Here we go. It's just larger and larger. Your bladder can give out. So worst case scenario, you can get bladder damage from your prostate getting too big. And at some point, you may have problems like so, requiring a catheter. So you may end up with a permanent bladder catheter coming out of your penis. That's the worst case scenario. That's why we like to treat it before we get that far and, keep bladder function. I got a question from Michael here. What if I have blocked arteries? Great question. This can be tough for patients who have blocked arteries. So, patients with histories of vascular surgery, if you had a history of coronary artery disease or heart attacks, where you needed a bypass, anything like that, typically that's what we call a systemic process or something that happens throughout your vessels. We can see narrowed blood vessels in the prostate all the time. So we'll only be able to tell by bringing you back. We inject contrast just like this. Where's my picture? So we'll see your narrowed vessels. These are pretty wide open vessels, but the narrowing will actually be in these small vessels and can be tough to treat sometimes. Sometimes they're completely blocked and your body can form what are called collaterals. And we have to get into these new blood vessels that have formed to the prostate. So it can make it challenging. But I have treated many, many patients with blocked arteries, and they've done pretty well as long as we can get in that blood vessel. Um, let's see. Got another question from Jesus. ED is typically covered by insurance. I have had colleagues do this procedure on patients, and insurance has paid, but that can be an issue sometimes. It may be out of pocket. Depends on your insurance. Got a question from Justin Bartos. What happens after 5 to 7 years? So vessels can grow back to the prostate. A new vessel can form. So this collateral vessel, this is what we call when you're born with a native prostate artery. This can get, we block, and then you can find another vessel coming down here to the prostate. It takes over as the new prostate artery. So the beads are permanent, but this lasts for about 5 to 7 years. The reason why is because you can get new blood vessels supply your prostate again. We can go back in there, find that vessel, and treat it. It also doesn't rule out your other options. So if there's something newer, better, safer that works, has higher efficacy, this doesn't burn any bridges, and that's the beauty of it. All right, I got a question from Craig. Does the prostate grow back eventually after a TURP? Yes, it does. A lot of probably buys you about 10 years or so. Depends on the TURP, depends on your prostate. But I have absolutely treated patients with the PAE after they've had a TURP. So what happens is, as long as there's blood flow going there, as long as there's hormones, testosterone in your system, your prostate's going to grow. And even after a TURP, sometimes that after it's been shaved off, that tissue grows back again, and you can end up blocked again. All right, I have Tamerly. I'm a woman patient at Urology Partners. Okay. And let's see. I'm happy to chat offline with you, Tamerly, if you have any questions regarding how embolization can help you. As far as treatments for women, sometimes we offer what's called a fibroid artery embolization. It's equivalent to prostate in men, but yeah. All right, I have a question from Gary. Can a weak bladder muscle be the cause of poor urine flow? And what would be the signs of this? Is this very common? Want to rule out all other causes before exploring PAE? So it can be. And there are many tests. You can talk about this to your urologist. Let's see, I mentioned it in one of my slides before. So some of the studies can be used to evaluate the function of your bladder. So one of the urodynamic tests, basically, they fill up your bladder with water or saline, and they have pressure cuff measurement. They can see how hard your bladder is squeezing. In general, this sometimes can be a cause if you have a weak bladder muscle that you can't urinate at all, and you end up with what's called retention or keeping too much urine in your bladder. And they basically test to see how well the detrusor muscle is squeezing. In general, I haven't seen it as an issue as poor or weak stream, but it could be. And these are the reasons why we have all these workup for enlarged prostate. Um, Sometimes the bladder muscle can weaken secondary to an enlarged prostate. So it can get thicker and eventually give out. So it could be both. Um, and we see that very often. We see that very, very often that you have part of it is your prostate that's enlarged, part of it is your bladder that's not working. So you can absolutely see some of these changes happen in your bladder afterwards. Um, but there's a lot of different options or a lot of different causes of lower urinary tract symptoms. So, it's important to explore every single one before, saying it is just an enlarged prostate. All right. Let's see how many people we have here. Question and answers. Any other final questions? All right. Got a question from John. Uh, Lifestyle changes first if I have the PAE procedure, and if I implement lifestyle changes too, can I slow or stop my prostate from growing back again? So the PAE procedure will shrink the size of your prostate. Um, but lifestyle changes are basically to try different things before trying medication. And, I think that they work together. So it's more like shades of gray. I don't think you can slow down or stop your prostate from growing back again, though, because that's just how testosterone works. Some of the medications, which can come with side effects again, that would be what slows down the growth of your prostate. So um, these are some of the medications. So the 5-alpha reductase inhibitors, finasteride is Proscar. That's a common medication that shrinks the prostate because it blocks your testosterone. Unfortunately, it also blocks your testosterone in other places. So you can have, uh, you know, decreased libido. You can have, weakness, erectile dysfunction, a lot of problems with having low testosterone. But weight loss, diet, trying these exercise, they're excellent. I would tell everybody to do it. They I'm not sure that they will be directly related to it, but they are correlated to it. So I'm not sure if you do these things that they will improve your prostate, or at least your lower urinary tract symptoms. I've got a question from Paul. When the bladder muscle weakens or gets rigid, when can be done then? It's a good question. I think that's a good question for your urologist to answer. In general, when we have it in the setting of an enlarged prostate, let's see, let me pull up a picture of this. So when we have it in the setting of an enlarged prostate, we can see trabeculation or muscles that grow in the walls of the bladder, and eventually that can lead to diverticulum. These are more so permanent, but the thickening in the wall sometimes can improve once we've fixed the obstructing prostate. So in some situations, when the prostate or the blockage down low is addressed, some of the thickening in the wall has resolved or improved compared to before, but it's hard to predict which patients that will happen to. Interstim effective. Interstim can be an option for a lot of patients. Um, it's a great question to talk to your urologist who performs interstim. I do not perform that procedure, so that'd be a great question for your urologist to see who's a candidate, who's not a candidate. Craig asked me, what is the approximate cost with Medicare? Um, I do not have that number on the top of my head. I do know that it is covered by Medicare, but as far as your out of pocket, that is something, we can talk or chat about offline, or I can get you in touch with my billing team if you're interested. Right. Paul also asked, do you recommend any supplements for BPH? So supplements are a great question. In general, there's not a lot of evidence to say which supplements work and which don't. I know some patients take saw palmetto. In general, I would say if it works for you and you find that it's working, you know, continue it as long as it's not causing you any harm. But as far as supplements that I find that work, there's not a whole lot of evidence that supports that. Um, in general, medications, tamsulosin, finasteride, those are the ones that have data behind them. So they've done, multiple randomized control studies where they have, tens of thousands of patients take it and they blind them, and they found that they have objective measures that find that these medications work. Um, the same cannot be said for some of these supplements. Although there's a lot out there, there's a lot of marketing, a lot of people that talk about different things. Okay, keep the questions coming. John asked me, are there standard workups done just prior to undergoing the procedure? Absolutely. So in general, there's different, it depends on your indication, but if your issues are with the prostate obstructing your urine flow, so it's not related to blood or etc., then we typically have imaging done before, whether that's a transabdominal, transrectal ultrasound, or whether that's a CT or MRI. So we have a size. Um, we typically have a cystoscopy where the urologist will place a camera inside your penis and they will look for other causes of lower urinary tract symptoms like strictures, like we mentioned before. They look for the narrowing or the degree of narrowing that your prostate is causing. And they also look at your bladder. So they look at how much damage has happened to your bladder, if there's damage at all. We also do what's called a post-void residual. Let's see. Post-void residual looks at how much urine's left in your bladder. And we look at all these things to tailor and come up with a plan that where it works for you. I think the most important thing to emphasize is to find a patient-centered approach. So figuring out, one, is this going to work at all? Right? So if it's too small or there's not a whole lot of blood flow, this may not work. Um, and two, are these risks something you're willing to undergo? Um, all right, I think we're coming at 8:30, so I have time for one last question from Justin. How often do you find anomalies in the prostatic arteries that interfere with a successful PAE? Great question. I would say rarely, very rarely. I think if you have a large enough prostate and you have open vessels, in general, it's a pretty technically successful procedure. I would say 90, higher than 95% of the time, probably about 98% of the time. Um, so there can absolutely be anomalies in the prostate arteries. They can come off of one of four, five, six different places. So, it's important to find somebody if you're going to do it, someone who has a lot of experience with this procedure, just so that they can evaluate every single one of them and get in there and get a good outcome for you. Uh, am I available for new patients? Absolutely. And so if you want to reach out to me here at this number, this is my office, 682-888-0886. We can get you in. We can chat about how maybe I can help you with this or something else. If you want to scan the QR code here, it links to my website, talk a little bit about what I do, as well as reviews if you're interested in any of that at all. All right, Tamerly, I've had a composition done. Okay, I'll be going back July for my 6-month check-in. All right, Tamerly, reach out to me offline if you want to chat. I'm happy to do it. Again, here's my information. If not, I just wanted to thank everybody for their time tonight. I know it's a Wednesday night, Wednesday evening, so I appreciate you spending time with me here tonight. If you have any questions, anything I didn't address, feel free to reach out to me. Just make a schedule, call my office. I'm happy to schedule a consultation for you. Or if you want to reach out to my website, you can reach me via email. I'm happy to address anything else. Thanks. Have a good night.